Okay, this is the first case. This is a 50-year-old woman with history of breast and ovarian cancer. The bone scan of the patient has been performed. The question is, which of the following would not be a physiologic site of uptake in the study? Bone or kidneys or bowel or both A and C or both B and C. If anyone want to share with me his thoughts in the chat will be good. As we know, in bone scan, sure, the bone will appear in the scan. Also, we all know that the non-visualization of the kidney in the bone scan is an abnormal condition which is called super scan. So bone and the kidneys should to be appear in the bone scan. So the bowel appearance, as in this study, is an abnormal uptake. So what is the cause behind this bowel uptake? In this patient has ovarian and breast cancer, and for the ovarian cancer, the patient take pelvic radiation, which causes colovesical fistula. So there is a fistula here between the urinary system and the bowel, which cause to see contrast within the bowel as in this patient. Okay, we'll go to the second case. This is 37-year-old man with hip pain. This is a bone scan of the patient. Given the finding, what's the most likely diagnosis? Osteomyelitis, osteoid osteoma, fibrous dysplasia, or osteoblastoma? Yes, as we see here, there is subtle uptake here in the left anterior superior iliac spine in the oblique zoomed images. There is here hot uptake noted here in the left anterior superior iliac spine. By review the previous imaging of the patient, there is subtle lucency noted here, which correspond to area, lucent area in CT with central nidus. So all these features are suggestive of osteoid osteoma. What is the typical treatment of osteoid osteoma? Is this external beam radiation therapy, wide surgical excision, radiofrequency ablation, or chemotherapy? As we knew all that radiofrequency ablation is the best treatment of osteoid osteoma, but there is some contraindication for this study, like in case of pregnancy, if the lesion seen in the hands, or if the lesion in the spine near to the spinal canal and the ablation will affect the spinal cord. All these are contraindications of the study. Okay, we'll shift to the third case. This is 44-year-old woman with bone pain. The question is, what syndrome might be associated with these findings? Is this Charge syndrome, Macon-Albright syndrome, or Abbott syndrome, or Cowden syndrome, or Marquis syndrome? As we see here, there is multiple longitudinal uptakes noted in the ribs as well as the mandible. All these are suggestive of polystotic fibrous dysplasia, like in case of Macon-Albright syndrome. This is polystotic fibrous dysplasia with precocious puberty and the café au lait spot. So what is Charge syndrome? Charge syndrome, this is briefly coloboma, heart defects, atresia, choanal atresia, retardation, and genital hypoplasia, as well as ear abnormalities like deafness. Albert syndrome, in which there is craniosynostosis, in which the coronal suture closes early, what's called brachycephaly, associated with syndactyly, which most of the time are complex syndactyly, and also there is abnormal shape of the face. This is Morquio. All of us know that Morquio, one of the mucopolysaccharidosis in which there is middle spinal beaking, and Cowden syndrome, in which there is multiple hamartoma syndrome in the skin, mucous membranes, the brain, breast, thyroid, and the gastrointestinal tract, and there is increased incidence of breast cancers in Cowden syndrome. So we have discussed three examples of bone scan. The first one was about the normal physiological uptakes, and for sure any site outside the normal uptake is abnormal uptake, like bowel in this case. And also we discussed another case about single uptake, and the other one about multiple uptakes. We will speak now about the examination itself and try to simplify this examination. We always use multiple agents in the examination. The routinely used agents are like MDB. The other selectively used agents like gallium or white blood cells radio-labeled with indium or hambao, or sometimes technetium 99M sulfur colloid or RBCs. The bone scan, as we said, we can use MDB. The half-life is 6 hours. The peak energy is 140 kilorictin volt. The tracer will accumulate after 2 to 6 hours after injection. About 50% of the injected dose localizes in the skeletal system. There are two factors which predict the uptake. The first one is the blood flow, and the second one is the rate of new bone formation, and cleared by glomerular filtration. And this is the dose in adult, if anyone want to know. How to image? Image after 2 to 6 hours, because this time will be higher target to background ratio, improved visualization of the bone by using gamma camera and low energy high resolution collimator. The patient should to be well hydrated, void immediately before the study, and void again frequently after the injection, because the critical organ is the bladder.